speaker for the day, which is Sarah Davis. She is from the Center for Patient Partnerships. She has a JD and an MPA. She is the Associate Director of the Center for Patient Partnerships and is currently collaborating with the new directors of national initiatives and educational development on endeavors in e-learning, professional field building, and activities related to enhancing the capacity of patients to influence state and federal health policy and the responsiveness of the healthcare system to consumer experiences. So today she's going to be discussing the strategies they use to ensure family engagement in a quality improvement process and introduce the framework they used, the steps that they took with providers and patients, and share the family engagement tools they developed as a result of these engagement efforts. Then the rest of our time will be a discussion and leading the group in a discussion around strengthening family engagement in the Transition Quality Improvement Grants. So with that, Sarah?
I am delighted to be here, and I can tell from this group, from the brief summaries that were provided to me and your descriptions, that there's so much you can learn from each other. And I know that having communities of practice like this is a tremendous way to make sure that everyone's work moves forward. So I'm thrilled to be here. What I'm going to attempt to do now is sort of the impossible. I'm going to, in 15 minutes, just really try to give some language and framing for this so that we can have a conversation and know that this is the commencement. So I'm providing you with materials that have been uploaded, worksheets to make this very actionable, and then links to resources that exist for you to continue to do this work. The other thing you should know is that I am our center, and I'm the representative. We're an ICDR CAP, so the Institute for Clinical and Translational Research. So we are available to provide free consultations. So if at any time you have questions or you've hit another barrier, do not hesitate to email me, and that information will be at the end of my presentation. Very quickly, as was described in the intro, the work at the Center for Patient Partnerships is really about ensuring that patients' experiences inform healthcare delivery, receipt, and action, and we do that in multiple ways, and the stakeholder engagement work that I'm going to talk to you about is really informed by all of those activities. I've been at the Center for 12 years, and at the core we help students provide free advocacy services, and so we are in touch with what is happening on the ground with patients right now, and we're always adapting our materials to reflect the realities. At the core of our work is this concept that patients are key members of the team, and certainly in many cases, patients and family members or caregivers, and so it is with that in mind that we approach this work. And when I talk about patient engagement, we use patient really as a shorthand to include family members, any other key stakeholders. Otherwise, it would be an incredibly long and sort of wordy statement. But we're really talking about an active process, a continuous process of ensuring that the patient's experience, wisdom, and insights are infused into this quality improvement work as well as into their individual care and broader system work. So here's what we're going to try to ambitiously do now in the remaining 13 minutes we have. I'm going to quickly introduce you to an engagement approach for quality improvement, outline the key steps, and highlight a few of them. I understand some of you are experiencing barriers and some of these sort of questions, so we'll address some key barriers in the forms of sort of myths and myth busters. We'll take an opportunity to have you start thinking about the unique issues that should result or do result when you're engaging youth who are transitioning, and then we're going to have our discussion where really we're going to take this and work together and really address some of the questions that you have. So let me briefly tell you about our engagement approach. I see there's someone here from UW Health U Station. 7 years ago, the UW Health was doing a primary care redesign and had a system that they were working to introduce QI methods and realized that it was really important, crucial to engage patients in that. So they contacted our center. At the time, patient engagement was essentially PFACs. That was sort of what was happening in this country. There was a lot more happening in not surprisingly, the UK, Canada, and Australia. So we developed a program based on what was happening at sort of hospital levels with PFACs and from internationally. So we really liked this Health Canada's public involvement continuum because it was visual and it really showed how interconnected all the different ways that you can engage are. So I know one of you, I think it was Gunderson, mentioned that one of your physicians will be presenting to the Pediatric Parent Advisory Group. I'm going to turn to this next slide where we took this continuum and created our frameworks. A presentation would fall under inform and educate at the bottom of this category where it's a one-way communication. That's important. It's incredibly important to get information and education out. But as you'll see, there's lots of other ways to engage too. So for example, if you have an interaction with a PFAC where in addition to informing them of the work, you're also gaining their insights and asking them questions, then you're either gathering information or you're having a robust discussion. You can see how that's walking up the categories here. And many of you have talked about including patients and family members on your teams. We really think of that as the partnership level, that the patients are full participants. So if you see on the right side of this screen, this really is a continuum. All engagement is valuable, and we really encourage a mix and match. So there's that question about too early and too late, and the way that you're going to see we think about this is that there are different kinds of engagement and ways to engage and people and stakeholders to engage. So it may be too early to have someone join your team if your team is still forming, but it's probably not too early to do some surveys or suggestion boxes, or to make some phone calls, or perhaps to do a focus group, right? So later I'll show you the PDCA cycle. Really, engagement can be happening continuously throughout the whole process. So we've got some principles, because you wouldn't have a framework without principles. So really, and all of this is in a toolkit that's available on the HIP Exchange. You really have to start it with your team believing that this work is important, and similar to front-loading the work or going slow to go fast, if there's hesitation, you want to take the time to do discernment, which is step 3, principle 3, because if people don't believe that patients and families really are going to add value, then it's not going to be effective. And you really do, when in doubt, engage early, because you're going to find out things that will completely transform your work. And it may be that you'll find out from your patients and their family members that the vision and solution that you were planning to implement isn't at all what they think will work. This work is most effective when you're having clear shared expectations and clear communication. You want to make sure that you're inclusive and addressing equity issues when you're engaging, that we're not just engaging the usual suspects, the people who it's easy to engage, and I'll give some sort of logistical information about that. And, some of these are going to feel like mixed messages, but really, it's best to just try it. If you're humble and honest with people and you try something with good intention and it doesn't go well, people understand, and it's better, in my opinion, in my experience, to do it and make some mistakes than to not do it at all. So go forth. Now we're going to talk about some key steps and considerations that came out of this model developed for UW Health. So we have a 6-step process. These are in a toolkit on the HIP Exchange, which you'll be able to easily get. Because we only have a few minutes, I'm going to highlight 3 of the 6 steps. But what you're going to see is, like I just described, the first step is to make sure that the team is on the same page, that everyone agrees that this is valuable work. Then you want to match the different methods that are available with your quality improvement effort or efforts. You need to define the job. Once you identify what kind of work you want various stakeholders to do, you need to let them know what that is. Then you need to be identifying and recruiting those stakeholders, those patients and family members, and this is where considerations of equity and inclusion come in. You need to invite patients, and they have the right to decline, right? So this really is about sort of a match where you identify your needs, you figure out patients you think would meet them. They get to decide if they're excited and want to be involved. And I know one of you said that that was one of your concern was how to get people engaged. And I know you have a little bit of funding on these grants, especially my gut says for teenagers that having incentives, having gift cards, having prizes, having money, keeping it fun, helping them to co-create agendas is going to be the way to truly have people say, yeah, okay, I'll come, right? Don't hold it at 7 a.m. on Saturday, right? Like ask them the best time to meet, and also where they want to meet, right? You know, it may be that you go to them instead of having them come to you. And then you want to create a welcoming environment, and that makes sense to all of us that you want this work to be something that you'd want to do. If you wouldn't show up for the meeting that you're organizing, then you're probably not on the right track. Very quickly, moving to the first step of discernment, really in the toolkit we provide team readiness surveys, myth and fact sheets, the engagement information, and concerns that have been noted by both patients and providers about this work and how you respond to that. My sense is that most of your teams are far along, but I don't want to understate the importance of this step. So methods. So this is where we get into talking about the fact that there's lots and lots of ways to get feedback from people. And engagement isn't just having someone on the team, as you saw in that ladder. If you look here, under the different categories, we've outlined lots of different ways to get feedback, which can include having suggestion boxes, having patients keep diaries, having forums, having a panel, sending information out in mailings, and certainly in having patients join your team or being on advisory councils. Then I would be remiss if I didn't remind all of us that we need to meet teenagers where they are, and there's a lot of value in using high tech when you're engaging. Be creative. Texting can be a great way to get feedback and to remind people about meetings. So there's a great article that I've cited here and placed this table that really helps you to think about a balance between high touch and high tech. What the literature says, and this is pretty common sense, you ideally want to start face-to-face to build a relationship and rapport and trust. But after that's established, you can do a lot via email, blogs, websites, texting. So keep that in mind, and that can be an efficient way to do it. One of you mentioned that, your hospital and clinics are in different locations. It can be a way to make sure that you're addressing rural and geographic issues. So this table here came from Engaging for Research, but the worksheet that I've provided for you changes, conductive research to conductive quality improvement work. So then you do this matching. We've talked about the different levels, and we've talked about the different methods. So then you want to think about your specific quality improvement activity and what method would make the most sense, or methods, to address that. And the other consideration, too, is who you should be engaging. So it may be that some aspects of your quality improvement work, really it's most important to be engaging internal people. I've heard about the workflow transitions that are happening at UW Health. I'm hearing about system-wide policy changes and the upfront work that needs to be done. No doubt in both those situations, internal stakeholders are being engaged, right? There's often political and policy work that has to be done to make it possible to make these changes. So I'm offering you a 4-step process to map who your stakeholders are. So you want to do a big brainstorming. You want to categorize them, determine how involved they want to be, and then create a list. And again, I'm providing a worksheet that will prompt this. You want to make sure that you're thinking about not just engaging the folks who are easy to engage. So consider all the possible valuable perspectives. I really like this jigsaw puzzle because it really thinks about diversity, I think, broadly, both in terms of how we approach learning and thinking and perspectives, and when in doubt, engage more people and get good insight. Ask people what they need to be able to serve, right? One of the best ways to figure out how to reach people who are hard to reach is to figure out what would make it possible for them to come. The location of the meeting, the timing of the meeting, child care, station, food. All right. So I know I'm wanting us to have time to talk. So very quickly to wrap things up, engagement is a continuous process that happens throughout the quality improvement cycle. What I've offered here are some various myths and sort of ways to address this, and I think it's going to make the most sense that we just talk specifically about the barriers that you're having and what I've experienced are ways to address those. So what I want you to do now is take about 30 seconds, and I'm sure you've been thinking about this before, but really think about what you think some of the unique issues with engaging, transitioning youth will be, what the specific barriers you anticipate, and how you think we could address those. So now we're going to have a discussion, and what you'll see at the end of this slide is reference to all the publications I have cited, my contact information as I mentioned, so we can connect if it would be useful. So let's chat. I'm really excited to hear how this might inform your thinking and make sure that we get every one of your questions answered.
Great. Thank you, Sarah. I think we'll just open it up. Please feel free to provide your thoughts.
This is Betsy from Milwaukee in the rheumatology clinic, and as I said, we have been working on transition here at main campus for about the last year and a half to 2 years, and everybody on our medical team is supportive of this, and we have had lots of positive feedback from our parents and the teens, and we're going to be rolling this out in the future. Probably our biggest barrier is because we are a subspecialty clinic, and patients come a distance to us, and there is a lot that needs to be accomplished in the clinic visit is time. And so time to address all their medical needs, the refills that they need, the diagnostic tests that they need, and sometimes transition gets low on the priority list. So we are trying to identify, obviously everybody is supportive of this and feels that this is important. Because that our patients are seen very, very frequently, we're trying to have at least a touch point at every visit, but it is something that it's always important to kind of discuss, even if briefly having them recite back to us that they now know their names of their medicines and they can tell us 1 or 2 side effects. But it's always a time factor because obviously you could have a whole visit discussing transition.
So here's a thought I have, and we should hear from your other colleagues as well. I understand that the Children's Hospital of Wisconsin Transplant Group is creating a transition class. Have you in Milwaukee considered doing some online modules and offering some incentives to your patients that between 2 visits they review the module on medication or whatever that, different transition issues are, and then, when they've confirmed they've done it, when they come in, they do a quick quiz or something, and then they get insert whatever teenagers care about. That's affordable.
This is Betsy again. I do have colleagues in pediatric rheumatology around the country and in Canada. In Canada, people have done some module work that we will be able to soon review and offer to our families as well, but that's a good idea. We, and this last grant for 2016, have gotten iPads that we can have in clinic, and the Arthritis Foundation has a toolkit that the teens can go to, and we have been starting to show them how, with the iPads, where they can find this and how they can use this, and that is something that they can use from time to time too. But that is a good, it's always good for us to continue to use the technology, as you said before, and social media.
I mean, you won't be surprised to hear me say that time in office visits is a huge factor, right, for everyone. And if you're trying to add something on top, as I hear you are, there becomes a point that there's no more efficiency to use to cut things, and you have to, I think, start extending essentially the clinic visit out into the world and out into people's environments, which is not a bad thing, right? We know that so much of health happens outside the clinic, so it's supporting a population health model to make sure that they're engaged, at home. So, back to sort of the texting idea too, if it's allowed, if you don't have patient information and it's allowed by your system, you could be sending prompts to be reading material you sent home or other things. Another question or thought?
So with the silence, I think one question that I would ask is, it does sound like some of them are clearly further along. They're in the process of creating these groups that are out discussing, but what are where did they start? If there's been no, other than the fact that they want patient engagement, and they don't know how to identify the families, how does somebody start on this path for family engagement?
I think if we go back to the slide about, here, we'll pull it up, sort of stakeholder mapping, I think a good first place is to identify who you think would be valuable to provide insights. And what was great in the introductions was to hearing, people usually immediately come to mind, right? People who are engaged in their care, are solution providers, and I think that those are incredibly important people to engage. I would also say that your most challenging patient, the kids who you scratch your head when they leave because they're not very good at taking their meds and they're not showing up all the time, right? They're probably crucial to engage. After you've identified what your needs are and who you think would be valuable, it's about inviting them. It's about finding out who on your team has the time, if it's a receptionist or a coordinator, to reach out to people and know that you're going to have more people in mind to engage than you need, because people are busy. People might not be available even if they're interested.
Right, and I think that is something that we had with grantees in the past, where they did an event and they put out their flyers and they had maybe one or two people say that they wanted to be part of it. And then the next time they did the same event, they also did the same promotion, but they asked their clinic coordinators, they asked their rooming nurses, they asked the physician to personally invite the person they were seeing in clinic. Say, I think you would be a good person to have on this group. And that personal invitation was really, really monumentally changing for the amount of participation that those groups had for later groups that they held. And that increased their number of participants by several. They'd have maybe 2 or 3 at one. At that one, they got 15. And so that was quite an increase for the number of people that they were expecting. They also held it at a time of night that worked for families. It wasn't too long. When they worked with another clinic, they offered things like child care. And of course, there's that incentive. Obviously, you're working within your system limitations on what you can provide and can't provide to families. But working within that to give them any kind of incentive you can to be part of it. Transportation was a huge issue, and child care was another consideration. So taking those things in mind when you're doing something of that nature, but not allowing them to be barriers to it. So I think that was really aligns with the steps to engagement that you are now on, and apparently it's not on the slide. But I think that's a good thing. Are there any other thoughts that have sparked from some of the discussions thus far? ideas on how people plan to proceed based off of what they've heard today, or is it changing the way you're going to do things, or are you feeling that this really just aligns with what you had in mind for family engagement?
This is Betsy again from Milwaukee and the Rheumatology Clinic. I think that you spoke about how that you can use additional methods other than face-to-face. I know this past year and a half, because the families that have been part of our team have lived a distance away, we have sent them information to review via email. We've phone called them. They've kind of given us a review of materials that we put in our binder, and then they've emailed us back, or we talk about it when they come for their clinic visit. So I think it's important that people realize that you can utilize those methods as well, and touch base with people when our team members, both the young adults, the teens, and the parents come for clinic visits. I usually use some time after that medical appointment is done, and then meet with them and have given them things to review for me or give me feedback on, and that has been successful for us.
That's great. It sounds like you really have been doing this for a while and have figured out how to meet some of the different barriers you have and allow other people to engage. So I had when I was developing a course, I had a patient advisory council, and one person exclusively participated by Skype. Like he wasn't able to leave his home, and he really wanted to participate, and there was absolutely no reason that he couldn't participate via video conference. And he had so much to contribute. So I think being creative in that way is great. And the good news is, if you're like me and you're a Luddite, there are people who know how to do this stuff or who understand it. You know, we recently at the center just hired a youngin who has a master's in digital technology or digital communication, right? And which is great because he knows what the youth and young adults are using these days, and how to make Instagram actually be your friend. So
yeah, lots of different venues to consider. At this time, I know there are maybe others who are not grantees who are on the line who are involved in family engagement, and we would welcome your thoughts and input at this time as well in the remaining 10 minutes. Just based off of what Sarah said and off of your experiences, would anyone on the phone in family engagement like to give any further feedback?
Maya, this is Robin with Parent to Parent, and I was just really impressed by this presentation. It was really well done, and it really fits with some of the research we've been doing in order to support family engagement in our work across the state. I really like the levels of engagement. I think that's really a nice piece for folks to look at and say, at what level am I going to engage, and that's okay because we build upon that with experience. The other important point I think that she made that we learned over the years that it's really important to engage not only the folks who shine, but the folks who are, when we think about it in the hospital setting, we think about the folks who have some negative experience as well, so that we can really think about making the system good for everyone. So I really liked that point as well. Nice presentation. I'm glad I was here. Thanks.
Wonderful. Thank you, Robin. Yeah, and I know that's always a hard thing to think about, is opening it up to the critical feedback, the things that you don't want to hear, that are part of the day in, day out, that you kind of blind yourself to because it's just something you're going to need to work in. And patients have no problem telling you that that's an area that you need to work on, and so hearing that's sometimes very challenging. But I think if you can look at it constructively and approach it from a planned perspective, it is definitely good feedback to be giving.